Good morning, everybody. We just decided to do more like a potpourri of cases, but essentially trying to expand on how this disease is so heterogeneous and so different. I think the first thing that it's important to understand is that there is ICAD in the stable patient, there is the ICAD in acute LVO, same culprit, different situation. The trials that David just discussed apply to the stable angina of the brain. That's the same thing happening in cardiology. However, we are dealing, in the cases that I'm going to discuss here, with the STEMI of the brain. It's a very different situation. You got to be a lot more aggressive. And I think it's a trial that you have to do is how to deal with refractory lesions, of which many are intracranial atherosclerotic disease. So the first question is how should we suspect ICAD, right? Like Mark said, we need to have a high degree of suspicion just so you can treat early. So we have these minor criteria based on demographics, like the racial profile, African American, Asian, Latin American patients, diabetics. In terms of non-invasive imaging, the absence of a hyperdense vessel sign favors ICAD. If you have evidence of moderate to severe unifocal disease on CTA, we believe that's a minor criteria. Absence of a probable etiology in terms of cardioembolus, a minor criteria. And there are major criteria. Mark just showed calcification at the site of occlusion. That's going to be ICAD, almost for sure. You can't count the calcification at the site. For evidence of moderate to severe multifocal disease on CTA or angiogram, the tapering lesion, pencil-like tapering, like he showed in his case, okay, with an absence of the meniscus, which characterizes a clot. And finally, the truncal-type occlusion that you can see on CTA. It is the work of our colleagues from South Korea. So when you look at this M1 occlusion here, and if on CTA you can see the actual MCA bifurcation, that's likely ICAD, in contrast with the branch-type occlusion where you actually can't see the bifurcation. Another thing that you have described is CT perfusion. You see a lot of blue, a lot of Tmax greater than 4 lesions because these people are highly collateralized. So these will increase your suspicions of ICAD before you start the case, right? Just so you can, as Mark said, adjust because one size doesn't fit out. Some technical considerations, Jinsu just talked to you. I really like his diagram here. Acute occlusion from ICAD responds very well, and it's very safe to use a stent retriever. We do it all the time, okay? It's very safe. But then immediately you have to load the patient on tyrosine or integralin. Otherwise, it's going to reocclude. And you watch, many cases you don't need to do anything else, but sometimes you're going to need to do angioplasty and stenting. We know from this SARIS study way back then that stenting is highly effective in acute LVOs. Some additional papers, but specifically I want to show this paper where they compare stent versus non-stent in patients that had refractory lesions in China, and you can see a shift towards better outcomes in stent. I really think you need a randomized clinical trial in this patient population. So how do you choose your stent? You should know the Morty classification. This is a great paper where you can use the Morty classification to use your self-expanding versus balloon-mounted expanding decision-making process. Here is how I would summarize. If the vessel diameter is greater than 2, I typically will try a balloon-mounted stenting as long as there is no mismatch in the tapering of the vessel. So the landing zones have to be approximately the same for a balloon-mounted stent. If they taper, you have to use something that will accommodate the stent differences across these diameters, a self-expanding stent. The lesion length, it's hard to navigate a balloon-mounted, so long lesions prefer to use the self-expanding, and obviously highly tortuous lesions self-expanding. You can oversize simple stents like even aneurysm stents and increase radial force. Here is what happens if you put a Neuroform Atlas 4.5 millimeters in a 2 millimeter MCA vessel, which I do a lot now. You increase your radial force by 4-fold. In fact, you essentially achieve the radial force of a 2.5 wingspan in a 2.5 millimeter vessel. So oversizing self-expanding stents is a good technique. We now have balloon-mounted stents that can go all the way to 2 millimeters. So a few cases, this is a patient that came already with an ACA establishing FART, good CT perfusion here. You can see an ICA occlusion. First thing you do, debulk the lesion. I like using the Trivo device for that because it really delineates the lesion for me. Here is with the Trivo, post-Trivo in place, so I can calculate the size of my stent. Post-Trivo, you see here that the lesion is persistent, an ugly plaque, I would say, so you cross that lesion. I typically use a J, very safe. You can see here the balloon-mounted stent. The key thing if you use a balloon-mounted stent is this. Get a digital access device, in this case is a 5 max DDC, put it up against the lesion, then you take your balloon-mounted stent through it. Then you can deliver it much easier, okay? And that's the best technique to use your balloon-mounted. You do your angiogram, you deploy, you're good to go. You are not done. You may have this angiogram, but you need to wait about 20 minutes with the patient on the table to make sure there is no early reocclusion, okay? And you can see here, essentially, the MRI just showing the previous ACA region stroke with nothing else. It is a different case in the Quanto Lateral hemisphere. Again, I like to show this because step one is debulking the clot. It was the ICA occlusion. You remove the clot first with the stent retriever, underlying lesion. You drop your balloon-mounted stent. It is a case of an M1 stent, balloon-mounted, where you have the occlusion right here, mid to distal M1. You do your thrombectomy first. And you have a residual stenosis with delayed flow. This patient actually had a previous stroke. You see the residual stenosis, no good landing zones, no mismatch. You advance your stent, look at the 5 max DDC here. I went all the way here, delivered it, took it back, and now you can just deploy your balloon-mounted stent in the M1. In this case, see again the 20-minute delay showing no platelet aggregation, then you are finally done, okay? And you can see here the full reperfusion. You can see before and after. So moving on to self-expanding stents, this is the MRI of the patient, again, just showing the deep strokes. So here is a case of self-expanding M1. Again, first thing you're gonna do is debulking the clot. In this case, was a long lesion, okay? Tortuous vascularity, and then you have mismatch in the land zone, so you're gonna plasty and then drop a self-expanding stent. This is a distal angioplasty stent in an M2, M3 with an NIH stroke scale of 14. Here is first, you can see the typical pattern with these border zone strokes. Surprisingly, there was no proximal occlusion. You see a lot of blue suspecting ICAD. And then you can see what's happening here. You don't see proximal lesion, but bingo. Very distal feeling. Patient has an NIH stroke scale of 14. You see the perfusion deficit. You have to find a view that actually shows the lesion, and you can see then this M2, M3. Sometimes the 3D is very helpful for that, but you see here the M1, M2, and then the M2, M3 area with this long segment stenosis. So you do your measurements. Tortuous proximally, you have to get very good distal support before doing the case. You can see here the kind of the hairline looming across, okay, on both planes. Then carefully you navigate with your wire, right? And then you navigate with, you do an angiogram, make sure you didn't do any harm by doing that. In this case, you have to use a small 1.5 millimeter balloon because you are very distal, right? So you do your plasty. Then you have to use an exchange length wire. It's very important. If you're doing self-expanding stents, exchange length wire to start. And then after that, you put your microcatheter up, and any self-expanding system. In this case, was an enterprise, as I said. I'm now using more and more. Here is the 21 microcatheter, and finally, the enterprise in place with complete resolution of the lesion. You see here a normalized caliber. Okay. And more, I'm using now Atlas because I don't need to call my RIB for these cases anymore. Use an Atlas. And just to finalize, so here is the MRI of this patient. I think this is the most important message of this talk. All these cases, I use full dose tirofiban unless I have preloaded the patient with 180 of prasugrel and the patient's therapeutic on the table. Please do not ever use heparin. It is a sad case in a patient that came with already an extensive temporal infarct, but high NIH stroke scale. She had this M1 occlusion. You do all our procedures not under general anesthesia, and you do even distal stent, as I showed that M2, M3 plastic stent was done under conscious sedation, or actually MAC anesthesia, I should say. So here is post stent retriever. Okay. So an ugly plaque, and then unfortunately I load the patient with 5,000 units of heparin before doing this. Beautiful result. NIH went from 14 to 0, actually 1. She had a visual field cut. And here is the 20-minute delay, showing essentially a TIC3 normal angiogram. You see, pretty normal. And here is what happened after an exam change, and I lost the patient. And unfortunately, I have seen that now a couple of times. So to summarize, please avoid heparin. This is a common, challenging. It's associated with worse outcomes because you are not intervening early enough, as Mark suggests. Stent retriever thrombectomy, followed by IA or IV tirofiban is likely the best initial approach. If you need them, you can rescue these patients with angioplasty and stenting using a balloon-mounted or self-expanding, as you explained. But please avoid IV heparin. Instead, try to bolus these patients with ticagrelor as soon as you can. Start to work in 1 to 2 hours. And then you can perhaps avoid even glycoprotein 2B3 inhibitors or cangrelor. Otherwise, you have to bridge with them. Very tight blood pressure control. And again, lesion-based choice of your best therapy. Thank you very much for your attention.
Thank you. We have some time for questions, if we could invite our speakers back.
You are invited to stay with us?
Absolutely. So I was asked to just present a robotic case for 3 minutes. Would that be okay?
Okay, go ahead.
So,
we have time.
All right. So this is, I think, one of the first robotic cases that it's done by a neurointerventional group. It's not the first carotid stent. I believe this is the 4th one, actually, in the country. As you probably heard, our great colleague, Vitor Pereira, has recently done an assisted, stent-assisted basilar artery coembolization. But here I would like to share our initial experience with the robot. 71-year-old gentleman that came with right-sided weakness, which resolved with medical treatment. He was loaded on double antiplatelet therapy. He did have these small hits, reinforcing the symptomatic nature of his lesion. You can see here the CTA with a pretty critical lesion, calcification, soft plaque. You see here on the CT angiogram, very critical lesion, a lot of soft plaque. So here is the baseline angiogram. The baseline angiogram, the robot doesn't help you yet. You have to do it standard way, then you bring the robot. So once the catheter is in place, you bring the robot, and I'll just show you some of the steps. So here I essentially loading my wire with my, in this case was a 6mm spider filter, okay? And then you can load both systems and you can cross the lesion very easily. This thing is extremely sensible, it's extremely responsive. After you drop the filter then, you unshift the filter, it does everything for you. You just have then to remove the filter at the end. We advance the balloon, angioplasty balloon with the robot. We remove it with the robot, but as you can see, the inflation is manual. Here is the result Now, after the angioplasty, you are advancing, you are removing the angioplasty balloon. The stenting still has to be done manually because the system is too big for a carotid stent at this, it's too small for a carotid stent at this time. You can see here that the RX system works very well with it. Here is essentially loading the recapture of the spider. Okay, so it works very well for the RX system. And then I'm recapturing the spider now with the robot and removing it. And then after that, I can manually remove the rest of the filter, but essentially everything is already essentially out of the patient. And then you can very easily remove the robot, and you just see how easily it
So
moves
you
around
think that you just
and finalize.
cut radiation? This is the great advantage because you can do it also manually. What advantage you find with the robot? Because I see only radiation reduction of the
So
stuff.
there are a few things that deserve. Let me just finish just showing the results here so you can see the before and after. Before and after, no residual stenosis when you compute here the differences, and before and after. And I just want to acknowledge everybody who helped with the procedure. But this is a new technology, okay? I think you're gonna have baby steps. Absolutely, you can do everything that the robot is doing manually, right? But there is no radiation, great ergonomics, there is no lead. In this case, I was wearing lead. It's my first case because I want to be involved with both steps. But you don't wear lead, there is no radiation. And the precision it's incredible, really. And there are certain tools, for instance, there is this ability that once you advance the wire, when you come back, it torques in a different direction. So I think specific for small aneurysms, you can go in the branch, come back, and it will essentially
fall
jump
inside
into
the side,
aneurysm.
yeah.
So the finesse of the movement, I believe it will, if it's not right now better than human, it will be very soon better than human. It's very, very millimetric movements you can adjust, and the torque ability is also
And the
spectacular.
time of procedure?
The time of the procedure, I think for the first few cases, you're going to increase the duration of the procedure. There will be a learning curve. There is a lot of loading and unloading of things in the system, but I think over time you're going to conquer this, feel more comfortable with it, and you're going to have the advantages of no radiation exposure, no have lead apron upon you, and I really think this is going to be a very promising technology. The other thing is, let's not only think about robotics. What's really promising is telerobotics. Being able to do a telethrombectomy in a rural hospital, I think that's really